This is the APP Grand Round session for the morning. Welcome Thursday early. For some of you East Coasters, I feel your pain. I'm in Indiana, and so therefore waking up and time change is a bit rough. I am Janie Yaley. I'm your moderator for today. I work at Indiana University Adult CF Center. I've been there over 20 years. And I would like to send out a get well soon to my, who was going to be my co-moderator, Erin Brozick. She just could not be here today. So I'm going to thank Debbie for helping me out here in her place. You're attending the APP Grand Rounds. The plan for today's session is that we're going to have 4 case presentations and then a short Q&A session right after each and every presentation. And then we're going to, the cases will include diagnosing, sustaining daily care therapies, use of biologics in CF, and also pregnancy. So some of the main topics that are out there for all of us, and some of them being a little more challenging than others at times. And then after the case presentations, we're going to break out into some smaller groups, and we're going to highlight the quality improvement work of the LEAPP program, which is the Leadership and Education of Advanced Practice Providers. The first round actually graduated in May of this year, and now we're into our second round. Can I have a show of hands of any of you who are new to CF as an APP? So we have quite a few. Well, welcome. Katie McAndrews has a brief announcement for you.
Good morning, everybody. I'm going to be really brief. Where's mine? Oh, there it is. I see a lot of familiar people here. I'm Katie McAndrews. I'm a nurse practitioner at Rush University Medical Center. It's a little early in the morning in Chicago. I see a lot of familiar faces, and welcome to those who are new. I'm here on behalf of the GLI Task Force through the foundation, and I'm just here for just a quick informative few slides on the new GLI predicted outcomes. So many of you might have known that. I have seen the changes recommended by the ATS, but as we all know, the FEV1 predicted is a key outcome for our patients in CF. And so in 2022, the ATS now recommends, supports the use of race-neutral reference equations as it most accurately reflects the disease status of our patients. And so what we want to do is start circulating this information to all of our CF team members and also our families to understand the new impact of the reference equations. We realize that this is going to be slow, might be slow. Some of you might already be doing this. Some might have never heard about this. But and to keep in mind that the data entry for the patient registry is in absolute values, and that the registry reports will transition eventually to the 2022 equations, although no date has been set that officially. Okay, so I don't know how to. Okay, so anyways, let me tell you, I've got one more picture slide. Do you know how to forward?
You should just be able to hit the button.
Okay.
Oh, it worked
Ooh.
earlier. Maybe face it towards the laptop.
Oh my goodness. All right, hold
It
on.
worked earlier. Sorry.
That's okay. Let's see. All right, so let me just, because I don't want to take any more time. I can't. So what I'm going to show you, if I can, as Jenna, is some scatter plots. There we go. On how it will impact some of our patients. So these are the scatter plots for the different patient population groups. And so for the predicted FEV1 for people who are white, it's going to increase. And that the percent predicted for people of black, who are black, will decrease. And we're not going to see a terrible amount of change in other race categories. So you can see how this is going to potentially affect and needs some messaging and understanding. And so I'm here on behalf of the GLI Task Force. We are here to develop resources for us as team members to talk to our patients, as well as references for our patients, because as you can see, this is going to have some changes. So sorry for the mishap, and I'm getting out of here. So
You're okay. Thank you. All right. All right, so now here comes our case presentations now. So our first speaker is Janice Lynn Doris. She is a pediatric pulmonary and cystic fibrosis nurse at the Center of Oklahoma Children's Hospital in Oklahoma City. She's been working with CF patients for the last 11 years. She received her physician assistant degree in 2012 from the University of Oklahoma and her bachelor's degree from the Southern Nazarene University in Bethany, Oklahoma. Outside of work, she spends most of her time with her husband and her 5-year-old daughter. As a family, they own and train horses and are involved within the quarter horse show industry. Please welcome Janice Lynn, and her presentation will be to diagnose or not diagnose. That is the question. So if it won't advance for you, I just went on the slide and I hit it, and then it went to the next one.
Okay.
But that should work.
Okay. All right. Well, thanks for having me today. Enjoy the opportunity to present this complicated case as an ongoing story in our pulmonary and CF clinic. We'll get started here. No, it doesn't want to do that, huh? You said you clicked here.
It's not working.
There we go. We'll use arrows. Okay, I have no relationships to disclose. So CF or not CF, that is the question. So our case is a 10-year-old African-American male followed in our pulmonary center for the past 9 years. He has a complicated history of severe persistent asthma requiring multiple ER visits and hospitalizations. He has severe environmental allergies. He also has obstructive sleep apnea with hypoxemia requiring CPAP therapy, as well as atopic dermatitis that would be considered mild. And overarching the case and our continued questions is the complication of non-adherence to medications and clinic visits. And I did want to note he was lost to follow-up from 2015 to 2020, which gave a pretty big gap in this 9 years of being followed in our center. So just want to kind of explain why it took so long to get to some of the workup that we've done. So when he returned to our center in the end of 2020, he was noted to have continued poor control of his severe persistent asthma, which led us to pursue further workup, which among other testing did include a sweat test. So his first sweat test was in January of 2021. On one arm, it was at 55. The other arm was quantity not sufficient for duplication. So we recommended a repeat testing. This wasn't completed by the patient until July of 2021. And on one arm, it was at 73, and the other, it was at 70. This, with his history, gave us concern for cystic fibrosis. So we recommended a hospital admission to treat with IV antibiotics to try to maximize lung function and his symptoms, as he was having ongoing daily coughing and wheezing, nightly coughing. And his FEV1 at the time was at 62% on his pre-testing and then 74 on his post. His physical exam at the time was relatively benign. We didn't hear any crackles, doesn't have any clubbing, has a normal BMI. Didn't note wheezing on the exam at that visit, but he does have intermittent wheezing. So upon admission, we continued our workup and certainly sent off for CF genetic testing. His CMP and CRP were normal at the time. His CBC did show eosinophilia with an absolute eosinophil count of 920. This would go along with his significant atopic disease. His IgE was quite high at 1,082, which brought concern for potential ABPA. So as far as that workup looked, his Aspergillus fumigatus IgE was certainly high, but when we got the Aspergillus fumigatus IgG, it was considered low. And that, in addition to his findings on his CT, which didn't really show anything in regards to ABPA, we decided to put that aside and not really pursue that. We thought the IgE could be related to his significant atopy. His fecal elastase returned low at 149 micrograms per gram, which is a moderate pancreatic insufficiency. And then his vitamin levels, A and E, were normal, and then an insufficient vitamin D. So as I just mentioned, his chest CT really didn't show too much. It showed some mosaic attenuation that was compatible with his small airway disease, but there was no evidence of bronchiectasis. His posterior pharyngeal culture at that time was also normal oral flora. And we did confirm that his newborn screen was normal. And in the state of Oklahoma at that time, his IRT was less than 65, or that was the monitoring parameters at that time. So for his hospital course, he was treated with IV tobramycin and IV ceftazidime for 2 weeks. He was noted to have improvement of his cough at the end of that treatment course, but there was only mild improvement in his FEV1 from 60% at admission to 69% at hospital discharge. We did go ahead and start CF airway clearance therapies, but after we got the results of his CF genetic testing a few weeks later, it did tell us that there were no mutations identified through CFTR sequencing, and this did include deletion and duplication testing. So from there, we referred him to genetics, and they completed a whole exome sequencing. This also returned negative. We referred him to our CF liver specialist. An abdominal ultrasound was completed, and that was normal. He did have this possible history of rectal prolapse through mom's stories, and seemed valid from what she explained to me. It was for a brief period when he was much younger, and but then hasn't occurred again. So it's not been evaluated by a provider or needed treatment. A repeated fecal elastase showed an even lower value at 33, indicating severe pancreatic insufficiency. Once that result was received, he was recommended to follow up, and he has failed to meet any of those visits with the liver specialist. So no further treatment recommendations have been given in regards to that. We went ahead and repeated another sweat test because we still were not understanding this full story, and a repeat sweat test returned still high at 57 and 58. So from there, he was lost to follow-up through most of 22. There were 2 brief hospital admissions in 2022 for asthma exacerbations. Upon return in the end of 2022, his season is his winter season with us, and then we don't see him for a bit, if you don't see the trend here. So we saw him again in the end of 2022, and his story continued to reveal poorly controlled symptoms of coughing and wheezing, as well as declined lung function. Of course, as the theme has been so far, there was still poor adherence to his treatment plan. Mom had difficulty recalling his medications, what he should be taking. The CF treatments have certainly fallen off by this point. And the patient can report what he was doing. Refill history also confirmed this. So we just continued to question, is he just not getting better because he's just not taking his asthma medications appropriately? But with our other findings in regards to CF, our questions still continued, and we thought we should still work that up. So we contacted the CFF MAP program, who is very helpful to us if you guys are not familiar with them. And they did recommend that we go ahead and send in a sample to them. This resulted in February of this year, and it showed no reportable variants in the CFTR. However, there was a CFTR-T TG tract abnormality noted with benign heterozygous variants of 9T, 10T TG, and 7T, 12T TG. So as far as a current update, his asthma remains poorly controlled. We did go ahead and recommend starting an asthma biologic while continuing the Symbicort 160 and then the Spiriva as controller medications for him. This took some work, but did get approved by his insurance despite his non-adherence, but he has failed to meet any of the clinic visits to start these injections. His FEV1 at his most recent visit was at 48%, but did show a significant reversibility of 47%. At that visit, we treated with a high-dose prednisone taper and just focusing on asthma treatments with that noted reversibility. He had a follow-up PFT a week later and had 0 improvement after completing that treatment. Questioned whether he took the medication. They promised he did. So we switched gears and started treatments with antibiotics and using his vest, and then changed up his steroid. And he has yet to follow up since then, so we do not know any results from that treatment change. I did want to note that at that last visit, his BMI was at the 75th percentile, despite the pancreatic insufficiency that's noted. And then I also want to note that his personal best FEV1 was at 86% in November of 2021. So this case really led us to consider, are there other possible false positive sweat test etiologies as far as diseases that can cause this? And so we came across this article that was helpful to guide us in like what other diseases to look into. And so we have worked through most of this list to rule them out for this patient. The only one that really continues to stand out and we see repeated in other articles as far as etiologies for false positive sweat tests is the atopic dermatitis. We don't know though, like as far as the severity of atopic dermatitis, how much that would influence the sweat tests, or vice versa. Does it cause that high of a sweat test or a lower sweat test value? So we don't know the specifics of that as far as researching that. So if the patient were to have a continued follow-up at our center and we were to see him again on a consistent basis, one thing that we have not been able to complete would be a bronchoscopy and a bronchoalveolar lavage to evaluate if there's presence of chronic infection. Another consideration would be a nasal potential difference testing. We don't do this at our center or anywhere in the state of Oklahoma. So given his social history, I think it would be really difficult to coordinate getting that done for him. Another consideration would be to refer to pediatric urology and evaluate status of vas deferens. So in conclusion, we have a patient with a positive sweat test, severe pancreatic insufficiency, persistent airway obstruction. Is this simply severe persistent asthma that's poorly controlled, or is there additional component of CF or something else? These are the references to that slide of all the false positive etiologies, and that concludes my case.
If anyone has any questions, please come up to the mics so that way they can all be heard by everyone else in the room. Or you can use the little app as well, but we prefer if you're, in the room, please come up to the mics and ask your questions. This was a very good case, though. That's a very good question.
Has he ever grown or any other organisms?
Yes, good question. He has not. I went back and did a thorough review of all the cultures we've been able to capture, and no, it's only ever grown normal oral flora.
So with his pancreatic, his fecal elastase being there, does he have GI signs and symptoms? I mean, obviously the BMI is a little lower, but is there any GI signs and symptoms that he's persisted
No,
with?
they have mentioned. I think there was maybe some intermittent constipation mentions.
Okay.
The only thing Mom would bring up would be that history of the rectal prolapse, but no other.
Thanks. Really good presentation. Mary Gant from SIP Center in Delaware. So we have at least two very similar cases. One almost I would have thought you were definitely talking about.
Okay, it makes me feel better. Not feeling
I deal with just adults, so not kids. So the one thing is, have you ever been willing to try pancreatic enzymes? And then secondly, has there been an exploration in social determinants of health as to why the lack of follow-up. And, is it financial? Is it travel? What could possibly be the reasons for the lack of follow-up? Yes. And the third thing is, why not diagnose with CF, right? What is it going to harm? We always have felt, well, that's not a significant positive sweat test because it's usually over 60. We have always felt like if it's a positive sweat, even if we can't find genotypes, we have an obligation to treat like CF.
Yes, yeah, and that's what we kept going back to is like pre-genetics. This would have been easy diagnosis of CF, no problem. And so, yes, that's what we thought as far as with the CF therapies. And socially, the minute I think I put my finger on why he won't come back, the minute I'm told that's not the case. And so, Mom gives a lot of excuses. They have travel provided. It's not really that. I think she works intermittently, so I don't think it's really a work thing. I think to me, it seems more of just, she just doesn't seem to care and, or understand despite our repeated teachings, but I don't think I can really give you an answer. I can say I have tried really hard. I mean, this patient I will call weekly, set up whatever time you want to come in, I'll see you. I don't care. And tell them to come in, and they just won't do it.
How about video visits? Have you started doing video visits with them? Maybe that's the way to reach?
Yes, I have. I do a lot of televisits still since 2020, and I have done those in the past. I think I've been resistant more so with them just because of our need to evaluate his lung function, even just in regards to his asthma and his risk there. And I think also wanting to just evaluate am I going to hear crackles at some point? But we could. I think really our next step, there would certainly be a consideration of calling DHS at some point. I do believe they've been involved in the past when he was under the age of 5. But that's definitely, actually, I take that back. There was another contact to DHS made by our lab because of an incident that happened there between the mom and the patient. And that was just within the last year. So I think that would be another step, especially if you were to present to the hospital again, which our season is here. So.
Hello?
No, he's got you.
Oh, okay. I'm Cindy Brady from Minneapolis. I just have a question about these variants of a TG.
Heterozygous. Oh, that's better. Do you know if they're in cis or trans? I mean, these may be novel, possibly some CFTR dysfunction causing variants. So has there been any parental testing with genetics to see if these variants may be on opposite alleles or in trans or on the same allele in cis?
Yeah, the good thought. We had that too. I don't believe Dad is around to further do parental testing, but we could certainly test Mom, and that would give us a clue on that. Yes, the polyT-tract stuff was poorly understood, and I was able to attend the genetics class yesterday and learned a lot through that. And from my quick learnings from that, from Karen Ray, it seems like those polyT-tract abnormalities that are noted are benign and are just a wild type variant. So after yesterday, I felt like I tried to rule that out. Karen has been real helpful with this case, and last she looked at it, she thought those were benign, but.
I am Nigat Mehdi. I work at the University of Oklahoma, and Janice Lynn is my partner there. So what I would like to add on is I have seen him mostly in inpatient. And literally, I've gone to the ER also to see him. Mom comes there, she tells everyone my son has CF. And as soon as they call me and I go there, he looks like a peach. He really doesn't look sick looking. And he does have a cough. He's well nourished. If you look at him, he's not like a puny CF looking kid. But certainly the fecal elastase is kind of low. So I think what we I think to myself, along with all these T variants, is that maybe he does have a metabolic disorder, CF-related metabolic disorder. I think probably that's where we are. And it has been hard because when he is inpatient, he's on a family practice service, and I'm a consult only. So I may write orders, but some of them don't get done because they don't feel like this is emergency, and they want to send him home as soon as he's better. So those are kind of things that hospitals are full, you don't have a bed. You can't keep patients for more than if they are on room air. They have to go home and come back for follow-up. But she hasn't been good about follow-up. And I think she has some personality issues because some of the nurses to report us that she's really good, and some of them feel like she's wanting us to take care of him while she's laying there sleeping. So I don't know, there is some family dynamics that we haven't been able to figure out. Like, she's not as worried as we are sometimes, I feel like, in spite of us educating her that he needs more workup and you need to come to the clinic. So maybe I'll give her a call myself. That's my, before I call DHS, my rule number one is let me call one time, because I feel like parents are the best for their own child. I hate to pull anybody out of their parents, especially if he's growing and thriving well. But again, certainly his lung function is low. So even if he doesn't have CF, I think he has asthma for sure too. So that is also very concerning because they do die. And but I will give her a call myself. But sometimes most of our patients, because they may be on sooner care, they may or may not have a phone number that day. We may have to try 2-3 times. And then if we fail, then we'll have the next step. I just want to make sure everybody knows we are not into DHS right away. So I think he has been confusing us, but again, he has valid points. He has asthma, allergies too, and he does have some with these new results that we got, for sure, some metabolic disorder related to CF. So we'll work on him.
Thank you. We have time for one more question.
I'm just going to make a statement really quick, Denise from Fort Wayne, Indiana. You have to be careful with the poly-T tracks because we have 2 patients that actually their poly-Ts are considered non-clinical significance, but we have 2 patients that literally one of the sweat chlorides became diagnostic at the age of 8 and one that became the diagnostic range at 18. So we are very scrupulous with our poly-T tracks, and if they are indeterminate, then we follow them every 6 months or a year, depending on their age. But we continue to do sweat chloride testing annually up until the age of 18. So just so you know.
Did they have other mutations with the poly-T tract?
Yeah, they both had 2 poly-Ts. One of them has a R117H in addition to that. But in all, one of them we're getting ready to say, no, you don't have CF. You just, but then we repeated sweat testing, and it actually finally came back diagnostic at the age of 18. And that kiddo, he didn't really have a lot of lung symptoms. He just had a lot of sinus issue, chronic sinusitis. I tried to get him to go to urology, which he was not interested in at all, because I said, we could definitely confirm CF prior to him turning positive diagnostic at 18 and look at the vas deferens, but he was not interested in that at all. So, but it is just so, like, we just have another newborn baby that's a poly 7T and an R117H that's just exactly like the girl that was considered non-diagnostic until the age of 9. And so we just tell the parents, the science on this is really unknown. And by all sense, you should not develop CF, but we're not going to say no until you're much, much older. I had read an article that the sweat glands actually reach full maturity at the age of 9 years. And so we do give them some confidence, because we've only had the one at 18, that if they don't turn diagnostic by the age of 9, they most likely won't, just to kind of alleviate some of the parental anxiety. But we've just been very, very cautious with these kiddos.
Mm-hmm. Thank you very much, Denise.
Thank you. Appreciate
very
your
much, Jesslyn. Our second speaker is Sarah Dykes. Sarah is a pediatric nurse practitioner at Dornbecker Children's Hospital at Oregon Health and Science University. Sarah currently specializes in care for children and teenagers with CF in the inpatient and outpatient settings. She is also passionate about quality improvement and recently finished the LEAPP program. Sarah completed her BSN at Gonzaga University and earned her master's and doctorate degrees at Oregon Health and Science University. Sarah's presentation today will be Why Connection Matters.
Wonderful. Good morning. Thank you so much for having me today. I'm excited to be here with all of you. Like Jana said, today my presentation is called 10 to 1, Why Connection Matters. So let's dive in.
If it doesn't go, just click on it because it's just issues.
I can click.
Sorry.
Wonderful. I have no disclosures related to this presentation. So to paint the picture, today I'll be speaking about a 16-year-old female that we follow in our CF center. Her medical history includes cystic fibrosis, pancreatic insufficiency, asthma, bronchiectasis, Pseudomonas colonization, reflux, and impaired glucose tolerance. Because of her variants, she was able to start Trikafta in fall of 2019. To further paint the picture, she's been in the care of her grandmother since the age of 5 because of her mom's difficult issues with drug abuse. Admissions, admissions, admissions. So what we have here is a graph of her FEV1 present predicted. To orient you to it, so on the far right-hand side is the FEV1. The bottom value is 34, and then it goes all the way up to 102%. And then at the top there, that's the range that we're looking at. So I focused on 2018 to mid-2022 at this point. So as you can see, prior to starting Trikafta on the left-hand side, her baseline was around the mid-70s. And then as we fast forward through 2019, when she was able to start Trikafta, we can see that the trend starts to increase. We see that there was limited data point at the beginning of 2020, mid-2020 when COVID began, and we were finally able to get a PFT value in July of 2020, and we can see that that was a big improvement compared to her prior baseline before starting Trikafta. Unfortunately, that's where our story begins today. So as we can see, she began to have a series of admissions. So each of those ticket points is each a general ticket to our hospital. So over the course of the next 18 months, this individual came to see us in the hospital for 10 separate admissions. Our hospital is located on a hill, so we have a tram. Needless to say, this individual was taking the tram quite a bit. So what do we do? So beginning with that first admission in October 2020, she had a new pathogen on her culture. She grew MRSA for the first time. So we said, all right, let's treat it. Let's eradicate. Unfortunately, the eradication was not totally successful. 2 out of the 3 repeat cultures did not grow MRSA, but 1 did. So when that second admission came, we said, great, this is an opportunity to repeat eradication. Well, ultimately, that eradication was successful. The admissions persisted. Around this time, this is when the individual shared with our team that she was experiencing more symptoms of anxiety and depression. So she was able to start on an SSRI. Another admission led to another new bacteria being picked up on a CF culture, so we treated that one. Next, we're starting to see the series of admissions continue. So that's when a team member had the great idea to inquire about her menses, and that's when we noted that her admissions were around the time of her menses, and we know that hormone suppression can help reduce the severity of symptoms and reduce exacerbations. So we offered this as a potential therapy to the individual. She ultimately decided that that wasn't something she wanted to pursue at the time. Another great option was counseling. Counseling was incredibly important to the individual. At first, she was reluctant to start counseling, but with the support of our amazing social worker on our team, she was open to the idea of it. This individual shares she has a really hard time trusting people, and so she was apprehensive about counseling. But again, that's where our fantastic social worker was able to walk her through of what to expect, what to look for, and so began the process of trying to find a counselor for an adolescent with state insurance in the middle of a pandemic. A difficult feat, to say the least. Again, as you all know at this point, the admissions continued. So at this point, their team pursued a CT scan. We know she has bronchiectasis, and so we wanted to do a CT scan to assess for any further changes. Overall, it was largely a stable CT scan. So next up was the bronchoscopy to assess for any other pathogens that we weren't picking up on an expectorated sputum sample. Fortunately, there were no significant surprises. Another admission told us she was having some more chest discomfort, and so that's with her history of asthma. Our team opted to increase her steroid inhaler dose. Another option that we pursued was doing a sweat test because we wanted to get a better understanding of how Trikafta was working with this individual. So her repeat sweat test showed that it was 26 and 24. So it went from her previous sweat test being diagnostic for CF to now normal CF, a normal sweat test value, showing that Trikafta was indeed helpful for her. Over time, we did learn that perhaps she wasn't taking her Trikafta twice a day, every single day, like she told us. Again, that's where our social worker was the person that she trusted immensely, and she shared with our social worker that she was not taking her Trikafta as successfully as she hoped, and she really was earnest in wanting to take Trikafta, but it was difficult for her to sustain that daily care. So about 9 months later, we did another repeat sweat test, and that's when her sweat tests were 58 and 64, which matched with what she was telling us, that she wasn't able to take her Trikafta twice a day as she had hoped to do. Another option that we pursued was doing an extra week of IV antibiotics. So maybe 2 weeks wasn't fully enough to get her fully recovered to baseline, and so we had her in the hospital for 3 weeks. And one of the other options we pursued was a niche referral. So our hospital has a great program called Niche, Novel Interventions for Children's Health. And this is an option for children with complex medical diagnoses that require a lot of medical care. And so it connects them with a specialized interventionist that assists with scheduling appointments, helps with coordinating missed schoolwork, helps with medication refills, helps navigate insurance challenges. And so this was something that we wanted to connect this individual with because of the disease burden that she was facing during this time. So around April 2022, this individual hit rock bottom. This is when she had personal significant stressors in her life. She felt she needed acute support during her inpatient safe. While ultimately she felt like she was safe, she definitely wanted extra support during this admission to help with her mental health. At this time, and in previous missions, psychology was consulted as well as psychiatry. Her SSRI dose was increased. And then another great outcome that came from this admission was there was a mental health telehealth study that was going to be done through University of Washington. And so this patient was able to enroll in a mental health telehealth study. What goes with that is this patient still hadn't been able to connect with a counselor throughout that whole time of trying over those several months when she was expressing that she needed to see someone. So the option to have a telehealth option was pivotal to her care. So fast forward 3 months later, she was able to do the mental health telehealth study. We learned from our social worker talking to the researcher that our individual patient attended every single telehealth session because that's how important her mental health was to her. She was also finally able to connect with a local therapist. She'd been seeing her weekly for 3 weeks, and she was actively working on her coping skills. And she really did feel like she was able to do her daily care. She reported doing all of her treatments, taking all of her therapies, and overall feeling better, which is huge. Fast forward another 3 months, she continues to see the therapist, working weekly. She's connected with an outpatient psychiatrist to better manage her medications, and she's been going to the gym and has a gym membership. And this piece was also really important to the individual. She used to be a competitive cheerleader, so being active and feeling good in her body was really important. So these were all major highlights for her. So fast forward a full year. She had her first admission. So what I hope this graphic shows you is the 10 admissions and that challenging time compared to the 1 admission once we got her mental health in a better place. What was also really cool that we don't get to see on the FEV1 trend is this was her senior year of high school. She had 1 admission that whole time and got to be with her friends. She got to go to football games. She got to be connected with what was important to her. This admission was because of a viral illness, so we know that she'll still have CF exacerbations from time to time, but overall, her quality of life was immensely better. So where is she now? This fall, she had another admission. What was exciting at that time, however, was that she had graduated high school. She had moved out on her own. She had a roommate. She was enrolled in taking college courses, and she had a job. So a lot of life changes. With that, she experienced more anxiety. She began to have some panic attacks, and so that's where she began to have difficulty again sustaining the daily cares that were helpful for her physical health. And so ultimately that led to admission after she failed outpatient oral antibiotics. And what I hope to convey is that it's a winding road. It's a journey, especially with mental health, that we need to continually ask those questions, utilize our social workers, and overall expand access to mental health services. So my takeaways for you today are to continue to think outside the clinical box, like that graphic showed of all those ideas and options that our team tried are so important, but again, this was a different bucket that ultimately led to the reduced exacerbations and better quality of life. Again, keep pursuing options to get people with CF connected to mental health resources. There's really no health without mental health. And like the World Health Organization quote says, mental health has intrinsic and instrumental value helping us to connect, function, cope, and thrive. Thank you.
Once again, if anyone has any questions, please come up to the microphone.
Hi, I'm Julie. I'm a pharmacist at Penn Medicine. Great presentation. My one question was, since it seems like some of her mental health concerns emerged after starting Trikafta, was there any concerns that was at play with her mental health, or was that explored at all?
Yes, it was talked about when we did the history with her and then the other psychiatry and psychology teams, and she acknowledged that she was having symptoms before starting Trikafta. Great question.
Any substance abuse? Self-medicating?
No.
Is she still following with the counselor and the psychiatrist now? Or?
She is.
She is, okay. Any other questions? Thank you very much.
Thank you.
Great presentation. Next, we welcome Catherine Stoll. Catherine is a pulmonary physician assistant caring for adults at Thomas Jefferson University Hospital in Philadelphia. She completed a bachelor's degree in cell and molecular biology at Westchester University, and then her master's degree for physician's assistant at Lock Haven University. She began her career in 2016 in the pulmonary and critical care, then joined the cystic fibrosis team in 2021. She also completed the LEAPP the program earlier this year. Her areas of CF interest include the pregnancy care and maintenance of health through recommended testing and screening. When she is not in the office, she enjoys traveling, spending time with her friends and sisters, reading and going for long walks, listening to crime podcast.
I am who I am. All right, good morning, everyone. Thank you for that introduction. I'm Katie Stahl, a PA with the Adult Center in Philadelphia. My case presentation today is Oh Baby, Insights from CF Pregnancy in the Age of Highly Effective Modulator Therapy. I have nothing to disclose. Before I get into the specific case I'll talk about, I wanted to go through a brief history of pregnancy in CF, kind of what we know so far and where we've come in the last couple years. The first successful pregnancy and live birth on record was in 1960, so we have about 60 years worth of information. The first case study that was published was in 1966, and it followed 10 women, and it was about a 50-50 split. 5 of those women did really well, 5 of those women not so much. Their lung disease progressed rapidly, and in fact, 2 unfortunately passed away. So after that, the general wisdom was to discourage women with CF from getting pregnant, particularly if they had more advanced lung disease. In addition to concerns about the safety of pregnancy, there was concern for subfertility and infertility related to CF, and that's been speculated to be partially because of CFTR and cervical epithelium causing more difficulty getting pregnant, and then just overall nutritional status, delayed menarche, and ovulatory cycles contributing to just more difficulty getting pregnant. However, as our therapies improved and longevity improved and just overall health, the number of pregnancies steadily increased in the 2000s with a huge boom between 2019 and 2020. A lot of you have probably seen this graph. It was part of the patient registry highlights. We know a very important drug came out in that time period, Trikafta, so we saw a doubling of the number of pregnancies. And with that, we realized that with that accelerated birth rate, we needed to know what that meant for our patients. So as of now, the Mayflower study is ongoing. Most of you have probably heard of it at this point. Started in September 2021, will run to December 2025. It's an observational study of pregnancy and CF in this era of modulators during and after pregnancy for 35 months so that we can see both maternal and fetal outcomes. From what I could find so far, premature birth does appear more common in those with advanced lung disease. Other findings are ongoing, and I'm sure will be talked about at other sessions at NACFC this year. With that background in mind, let's move on to our patient and her background. She is a 36-year-old female with her cystic fibrosis diagnosed at age 2. She's homozygous for the F508 delta. She has CF-related liver disease, pancreatic insufficiency, and is chronically colonized with mucoid and non-mucoid Pseudomonas. She has dropped into really, significant advanced lung disease in the last 5 or more years, and her FEV1 was hovering right around 30%, and she was referred to a lung transplant center before she started on Trikafta. She had some nutritional issues as well and had a G-tube as an adult, but thankfully that was able to be removed in 2020. She's had one previous pregnancy in 2007, so 16 years ago. Her FEV1 was better, but not normal at that point. She hovered between 55 and 70% predicted during that pregnancy. When she's well, her routine medicines over the past year have been her Trikafta or ETI at a reduced or half dose. She does airway clearance with albuterol, Dornius alpha, and Vest twice a day. She's on inhaled tobramycin every other month, enzymes, and multivitamin. She does have a portacath in place, although thankfully we haven't had to do IVs more recently. Despite this, she works full-time in healthcare and supports herself and her family, which does not just include her biological child, but she has custody of 2 other children. So she's responsible for 3 children under 18. This is her spirometry from the past 3 years. I wanted to highlight a couple of them before we move into her pregnancy. The red is when she had to actually come completely off of Trikafta when she had a liver function bump. So she did well on it for about the first year that she was on the full dose, but then she had a bump and we had to take her completely off. She had hovered with her FEV1 above 1 during that time, which was really good for her. But unfortunately, she dipped down in February when we got numbers off of Trikafta. Once she got back onto a half dose, she eked back up above that 1 liter. In June, that was her first visit with us, the blue arrow, after finding out she was pregnant, and the green was the most recent in September. So she is dropping a little bit through the pregnancy, and I'll talk about what we did about that in a moment. So she let our team know in April of this year that she had a positive pregnancy test and that once she was evaluated with OBGYN, her estimated delivery date is in December. She's about a month out from her due date as of today. She is well established with OBGYN and maternal fetal medicine and has been having appointments about every 2 weeks for the beginning portion of her pregnancy. She had a negative glucose tolerance test, so she does not have gestational diabetes, which we were slightly surprised by, but super excited about. Unfortunately, her weight gain has been minimal over the course of the pregnancy, but thankfully her BMI was normal prior to getting pregnant, so we were a little less concerned about this, although still not an excellent weight gain in her pregnancy. She moved to weekly antenatal testing once she hit 32 weeks per her OBGYN's recommendation, and she is still working full time. I don't think she's even on light duty at this point, and she is a month out from her due date. So in CF clinic, we've seen her several times since she has become pregnant. June was the first one post-pregnancy test positive. She's remained on her airway clearance with her typical albuterol, Dornius alpha, and Vest. She self-discontinued the inhaled tobramycin because of concerns about tetracyclines. At that visit, she noted she was a little bit more congested, so we decided to add azithromycin instead for her Pseudomonas coverage, and she responded well to that. She followed up again in September, and based on both her numbers that visit and also that she just was feeling a little bit more sluggish and was interested in trying full dose Trikafta for the remainder of her pregnancy, we got updated liver function tests. They were normal. She went up to the full dose, is feeling better, and her repeat LFTs at 4 weeks starting that full dose have still been within normal limits, which was really exciting for us, so she can stay on the full dose for now. We did recommend she follows up once a month with us for the remainder of the pregnancy, more frequently if needed, and we have contact information between ourselves and her OBGYN team so that if we do need to move forward with like an induction or anything earlier than due date, we can make that happen. So this patient case is near and dear to my heart because I am a champion for our patients wanting pregnancy, and so many do. You know, that's what the data is showing us, is that many of our patients with CF desire pregnancy, and some may surprise you. I have to say I was surprised when she came to us and said that she was pregnant, and I think some other people on my team were as well. So I think this shows that we should be having more conversations about it, and we should be really open to hearing this from our patients. With the improved health and longevity, we're seeing an increase of pregnancies, as I said, amongst the CF population, even in advanced severe lung disease. And we're finding out what that means in the age of modulators. Before, the wisdom was this is really not a good idea. Now we're finding out what that conversation should look like in the age of modulators. And we're still also learning just what it means for overall health outcomes. Communication between our CF teams and OBGYN, especially as we're seeing more and more pregnancies, is of vital importance. We need to make these relationships so we can have good outcomes for everyone. And partnering with your patients to fulfill their life goals is an important part of our role on the CF care team, and should be at the end of the day, our main goal is their health so that we can help them fulfill their goals. Thank you.
Does anyone have any questions? I know I do.
Great. Let's hear it.
Yeah. I'm just curious, because you stopped the tobramycin, did you ever consider doing Caistin in its place?
We did. I believe she'd either had a poor response to it or Jeff, come to the microphone. She's allergic to it. That's right. She's allergic to it. Thank you. Thank you, Christina Gallery.
Yes.
Ooh, they were at least. Oh, sorry, repeat the question. How bad were LFTs that we decided to discontinue it completely? I think they were like 2 standard deviations above normal. It was pretty, I don't remember the exact numbers, but it was pretty high. It was bad enough that we were like, you need to stop it completely and let detox happen, basically.
Was there any consideration, like that there's some data with like sudden discontinuation of Trikafta leading to decreases below baseline? Was there any like tapering off consideration, or was it just withheld?
I think we were so concerned about it that we just said cold turkey. And in fact, I didn't include this, but we went to an alternate, I think we did Symdeko briefly because she had such a poor, reaction to the Trikafta. But then eventually, since that wasn't helping her lung function kind of bump back up, we went back to the Trikafta at a reduced dose. So yeah, there were a lot of conversations that happened. I wasn't as involved in those decision making, so I'm sorry I don't have exact numbers and everything for you, but that is what happened.
Hi, Lynn Freeze, adult, Buffalo, New York. Communication with MFM and OB sometimes can be a little tougher in reality than, and I know with our MFM people, they're about 10 years behind. We have patients that go and they're like, oh, this is very dangerous. And, so on my to-do list on my board is like, meet with MFM or do rounds for them.
Yeah.
So I should do more due diligence, but does any have a nice canned education thing that they give their OBs? I'd love to have it.
Yes, that can be a question for other people as well. Jumping off of that, it's been a little tougher because she's outside of our health system for her OBGYN, but I did give a talk to our maternal fetal medicine team about 2 years ago and gave them some updates on what's happening with CF and pregnancy more recently. So that was really nice to kind of update them, and I sent them my slides, and I still have those slides if you are interested in me sending those at least to you, but I don't have anything truncated. I apologize. I don't have like a 1-page, like here's what you should do and what you shouldn't do.
Katie, great job.
Thank you.
Awesome. I'm Maureen from Stony Brook. I'm one of the PAs. I just had a question. Is anybody doing echoes on their advanced lung disease pregnant patients to assess for pulmonary hypertension?
That is an excellent question. We have not, but it is not a bad idea. That is part of the workup just for advanced lung disease in general. And that may be a QI project, especially since there's more pregnancy now that we are following. So excellent idea, but our team has not done that, but we should.
And one other question, have we already started the topic of contraception during this pregnancy with what's going to happen after?
We have not. And I don't know if the OB teams are usually pretty good in my understanding of having those talks, like even close to postpartum. But no, I haven't brought that up to her. I don't think anyone else on the team has. But you're right. It is important for her health and well-being to not have back-to-back pregnancies.
Anyone else have any questions?
Was she seen by hepatology? I believe we did refer her over. Yes, she did have an initial evaluation with them, yes.
All right. Thank you, Katie.
You're welcome. My references real quick.
Our final presenter is Jasmine Jimenez. She is the coordinator and the pediatric nurse practitioner for Texas Tech Health Science Center in Lubbock since 2019. She has established a high-risk asthma clinic which aims to reduce hospital readmission and minimize recurrent exacerbations in asthma patients across West Texas and Eastern New Mexico region. She is working on obtaining her doctorate at Texas Tech and is working to expand access to care through telemedicine in a school-based health clinic through Lubbock Independent School District. She recently completed the LEAPP Fellowship program as well in May. Her interests include spending time with her husband and her 3 girls outside of work. She will be presenting cystic fibrosis and asthma post HEMT and multi-case study review.
Hello, it's good to be here today. I was excited to be here in Phoenix while the Texas Rangers won last night. I have no disclosures during this presentation. I kind of wanted to, I talk about this a lot during my fellowship, but I wanted to show all of you the area that I serve. This is a map of Texas, and our area is what's circled, and we have a very large service area of West Texas and Eastern New Mexico for our CF patients. In this area, it's very rural. We have lots of agriculture, and you can kind of see that with the picture on the right. We have a lot of dust storms. People who aren't from the area are kind of scared when we get our haboobs because the sky is brown when this happens. Just something to keep in mind throughout my presentation. So our first patient, oh, I'm so sorry. This computer's a little sensitive. So our first patient is a pediatric. He is 8-year-old male with cystic fibrosis, pulmonary and GI manifestations. He has severe persistent asthma, environmental allergies, and reflux. I wanted to show what his lung function was, prior to starting Trikafta, which you can see his FEV1 is 55%. And as many of us saw after Trikafta was initiated, that lovely increase of FEV1. However, his did not sustain for very long. We do see a decline even after his initiation of therapy. And this arrow shows how he had several asthma and CF exacerbations, 7 total, and 4 of those resulting in hospitalizations. So during this time, we, asked ourselves, he was treated with IV antibiotics and he's on step 4 therapy of his asthma. Even was started on high-dose Symbicort, Spiriva, Montelukast, and a antihistamine. So we decided at this time to do repeat his IgE and look at a CBC with differential to look at his eosinophil count. At this time, he had an elevated eosinophil total eosinophil, and his IgE was in the 600s. And with his recurrent exacerbations, many of the times he did have a pre and post done, which showed significant improvement in FEV1. So at this time, we decided that due to the elevated IgE, we would go ahead and try a biologic. We started that in January of 2023. And since that time, from January to 2023, he went from having 7 exacerbations and 4 hospitalizations to just 1 CF exacerbation and asthma. After you saw the decline in the previous slide here, he went down to the 60s, and he sustained that, during his illnesses. It kept declining. And after start of his biologic, his FEV1 now is 84%, which was similar to what we saw with the initiation of Trikafta. So the next person I want to talk about is an adult. I primarily treat pediatric patients, but I just thought during my fellowship I did get to see both pediatric and adult, and I know many of you work with adults, so I just wanted to highlight this as well. This was a 28-year-old female who had moderate persistent asthma, CF-related hepatic intrahepatic cholestasis, pancreatic insufficiency, and also environmental allergies. You can see here from her list of medications, she's on a step 5 therapy for her asthma. She also had an improvement following Trikafta initiation, but was still having recurrent asthma exacerbations. Since February of 22, she had multiple asthma exacerbations and mild CF-related exacerbations requiring oral antibiotics and prednisone. She reported the symptoms she reported at the time of visit were nasal congestion, headache, cough, and shortness of breath. She noticed these changes in her symptoms during weather, which is something we hear a lot in West Texas. We'll hear after that recent dust storm, after the rainstorm. That's something very common for our area. I'm not sure if that's something that many of you guys hear. And her total IgE was 445. So she was also started on a biologic, and based on her IgE, this had to be every 2 weeks. And here is her pulmonary function testing. After she was started on her biologic in August of 2022, even though we don't see this large increase, what changed for her was her FEV1 was able to go back to baseline. The first, it's hard, I don't know if I can use this pointer.
If you push the red at the top, there you go.
This first was right when she was initiated on Trikafta. These are her exacerbations, and this is after starting her starting her on a biologic. So what did this minor increase here change? It changed her quality of life. During the time when she was having these symptoms of headaches and nasal congestion, she reported not spending time with friends, wanting to stay inside because she was worried about how these symptoms were going to affect her. And she no longer had to be on recurrent oral prednisone for her asthma. And then just overall decrease in her burden of care because she wasn't having to have additional medications during this time because she wasn't having exacerbations. She went from coming into our clinic being very sad, knowing that she was having an exacerbation, having headaches. She's in college, and so she started being upset about not really being able to interact with her friends, to coming in after being on therapy, saying that she was able to, smiling, saying she was able to go back out, hang out with her friends. She wasn't having these intense allergic symptoms that was causing exacerbations with her CF. In In March of 2023, the study came out for monoclonal antibody therapy in cystic fibrosis and asthma. And the observational data shows monoclonal therapies in patients with CF and asthma reduce exacerbation rates, improve symptom scores or quality of life, reduce antibiotic use, shorten hospital length of stay, and are well tolerated. Improvement in outcomes following biologic therapy for asthma in patients also on modulators appear to be an additive and not solely due to CFTR modulator therapy. This study, the time that they looked at it was challenging because they looked at it during a time when the CFTR modulators came out. And so the question was, is this the CFTR modulator? Is this the biologic? And they were able to determine, no, this is a combination of both. So my conclusions is that early detection of asthma for patients with CF utilizing pre and post bronchodilators is very important during a time of an exacerbation. The role of asthma in CF or in refractory lung disease in treating it, the underlying cause of inflammation, whether that be a high eosinophilic type of asthma or IgE, is important. And then knowing your geographic region, for us in West Texas, we kind of know when our patients are going to be having higher exacerbations, depending on, is it cotton season, is it haboob season when we're having these dust storms. And so what I wanted to highlight for the future is that, this is something that is being talked about frequently. You can see in these different studies the impact of air pollution in the course of cystic fibrosis, the effects of air pollution in children. Ozone is associated with increased risk of respiratory exacerbations in patients with cystic fibrosis. These epidemiology studies on CF patients have highlighted increased risk of exacerbations, primary infections, and reduced lung function associated with air pollution exposure. Actual individual exposure depends on factors and time spent outdoors, distance from pollution sources, and weather patterns. For example, meteorologic conditions are of primary importance because of the pivotal link to both CF and pollution.
Do we have any questions?
Thank you very much for this. I'm from Oklahoma, right next to you, and so I can totally feel the environmental changes being a part of this. So I really appreciate getting to hear about asthma and CF, as I take care of the asthma kiddos too, as you guys saw. And so I was just curious, how did you go about choosing which biologic you did?
So unfortunately, as many of you know, a lot of this is dependent on insurance. But for these two patients, there's about 4 or 5 different biologics on the market right now. Some of them only treat, eosinophils. Some of them treat both. And for these two patients, one of them was chosen just because of insurance, because he had a high eosinophil and a high IgE. And so there was a different biologic that we wanted to treat him with that targets both. However, insurance had asked us to try this medication first. But typically we just go based off the CBC with differential, looking at whether they have high eosinophils or high IgE, and just target whatever is elevated.
Thank you.
Yes.
Cindy's coming up to ask you a question. Okay. It's okay. We'll wait for Miss Cindy.
These are great cases. I also have taken care of a lot of patients with difficult to control asthma, and I'm wondering your thoughts using smart therapy, single maintenance and reliever. I've found it, especially when you've got a lot of regimen complexity, it seems to be a game changer. And I really applaud the use of pre and post bronchodilator spirometry. It just tells you so much in trying to tease out a CF exacerbation and an asthma, how much asthma is talking, during that visit. So your thoughts on smart therapy or experience?
So with smart therapy, we what's really amazing about the biologics is that once they start on this, we're able to take them off. These patients were able to come off Singulair and Spiriva, so that decreases the burden of medications, and then oftentimes can step down on their inhaled corticosteroid. So one of them goes from Symbicort 160 to maybe Symbicort 81 puff twice a day. What makes it hard for us for the smart therapy for some of our asthma patients is if they're utilizing it as needed, they won't have enough to cover them for the whole month, and insurance will not cover two inhalers for maintenance per month.
That's definitely a problem we run into, but I would say keep prescribing too and keep bugging them, because things are starting to change and we're getting it covered more and more. It's this quantity override.
Yes.
But just keep at them is what I would say. It's more burden, I know, for all of your people.
Yeah.
But I've noticed in the last 6 to 12 months, things are changing and they are covering it.
Oh, that's good. I think we need to keep pursuing that, because we did kind of give up for a little bit.
Yeah. Hi, Brad Rosen, Indiana. So topic really near and dear to my heart, and also an area that I'm pretty familiar with.
Oh, nice.
Question I have is, in terms of de-escalation after being on Trikafta, were any of these patients, I may have missed it, did they stop taking their azithromycin? That has implications for both asthma and CF, and I'm curious if that was something that you noticed or have noticed.
No, they did not. I haven't noticed that with some of these patients. I grew up in this area, so I don't know anything different. But the physician that I work with is from Buffalo, New York, and she said the incidence of asthma in this area is not more. It's not any more than what you would see in the general population, but the severity is worse. And it's very, very just by what we're surrounded by, because of the environment. I just feel like we have even in my asthma clinic, it's very severe patients. And many of them we've had to step to biologics. So it would make sense that, we would do that with our CF patients as well. And I think what's helpful with starting the biologic early on for our patients with asthma who need it, because when you're on a step 4 and 5 therapy, you have multiple medications that you're taking a day and they're not working. They're not making your symptoms better. So in the patient's mind, why take it? Why take this medication if it's not working? And then the biologics kind of remind me of Trikafta for our asthma patients. When you give it to them, their symptoms get better and their FEV1 gets better, and then the medication burden is improved. And so because of that, we do see a better compliance rate.
Probably in the asthma world, there's going to be a move towards more early use of biologics and targeted therapy,
Yes.
and then de-escalation, exactly as you did. So very nice.
Thank you.
Any other questions?
I have a loud voice, I'm just gonna ask. How long do y'all plan to keep people on the biologics? I mean, we all know they're relatively, well, Xolair's not new, but the others, what's the trajectory? How long?
So we did have one patient on it for 2 years, and then due to a loss of insurance, she had to come off of it. And when she had come off of it, her asthma was well controlled. Still on a lower dose therapy. And then oftentimes throughout therapy, we like to check IgE levels, because sometimes the IgE levels will go up and we actually need to treat with a higher dose of the biologic, depending on which one. And then sometimes they will decrease. And so some of that is dependent upon what biologic they're on. And then their symptoms.
Any other questions? Thank you very much.
Thank you.
That concludes our case presentation. So now what we would like to do is highlight some of the QI work, quality improvement work that was done by our graduated LEAPP fellows from May. So there are some tents kind of set up with some topics, various topics. So therefore, if we'll just break out into some smaller groups, and then they will go over with you the actual project. And then I just encourage you to ask questions, possibly give them more things to even advance further this QI project. Another thing to look at and venture into. And so we have various topics, and perhaps maybe if the graduated fellows, could come up to the microphone and let the folks know what your topics are and where you're located, and then that way they'll know which area to go to.
Hi everyone, my project was on completion of baseline safety assessments prior to starting modulator therapy, so I'll be up here in the front.
Hi everyone, good morning. My name is Emiko, and mine was about improving audiologic screenings for patients who are on potentially ototoxic therapies, and I'm over here in the front as well.
I'm Catherine Stull. You may remember me from a moment ago. I did a project on improving colorectal screening in the adult CF population, and my table is right here.
My name's Amanda. I did a QI project on everybody's favorite test, OGTT, and I'm over that way.
I'm Maureen, PA from Stony Brook. My QI project was on med reconciliation and trying to correct them and make sure they're accurate so there's not harmful outcomes for patients.
I'll be back.
Hi, I'm Michelle McKenna, nurse practitioner from Children's of Atlanta, and mine was on establishing a CRMS clinic run by NPs for 2 years and above, and I'll be right back there at that table. Thank you.
Hi, everyone. I'm Laura Beth Gifford from Chapel Hill, North Carolina. I did a project on improving care for our advanced lung disease patients in our adult clinic, and I am kind of mid-back left.
All right, if everyone would like to kind of go to whatever area you might be interested in and have a good discussion.